Welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we bring this podcast to you every Wednesday as a veterinarian, as a technician, as a dentistry team to help you be even better at veterinary dentistry in your practice. We're sponsored and partnered today with the Veterinary Dental Practitioner Program. If you're interested in being among the best anywhere in general practice as a team in veterinary dentistry, I invite you to request an invitation. Just go to ivdi.org/INV, like invitation, first three letters INV. So IVDI, International Veterinary Dentistry Institute, ivdi.org/INV, and we'll get you the information that you need. So let's move into the topic for today and give you a little overview of how we like to do anesthesia in light of the fact that we can use nerve blocks. So in order to be able to keep the patient at a light plane of anesthesia, if we're doing our regional nerve blocks correctly, then we are blocking all of the C fiber stimulus from the oral cavity from reaching the cortex. And in so doing, the patient feels nothing. And so we can do surgery, we can do mass removals, we can do mandibulectomy for cancer, maxillectomy, and they don't feel anything. But many times with our patients, because we keep them very light under anesthesia, because we can with the nerve blocks, when we turn them, they may ambulate, or they may retroflex their neck, or they may otherwise start breathing more rapidly just because they feel that movement, but they don't feel what we're doing in their oral cavity. So it's a tremendous way to maximize the safety of anesthesia with increasing your efficiency in keeping that patient under anesthesia the least amount as possible and at the least depth as possible. And the way we do that is we just for not necessarily that you need to do this, your protocols are probably fine and may differ from ours as far as pre-meds go, and that's fine. But just to give you what we use midazolam and hydromorphone in dogs and midazolam and buprenorphine in cats as a pre-med 20 minutes or so before we do the procedure. And then we induce with just enough propofol to get that tube in without the patient chomping down on the technician. And then as that intubation proceeds and the patient's hooked up to gas, then we keep them very light so that they're breathing rapidly. They've got a nice rapid heart rate, and they're near waking in the respect that many of our patients, and I would go as far as saying most of our patients, we still have a palpebral reflex. They're that light, but they don't feel what we're doing. So in that respect, we can expect the heart rate, the respiration rate, the cardiac output, the blood pressure, and consequently with that, all of those parameters near normal or near waking, the patient perfusion and oxygenation is at its maximum, so they stay warm. Even those little bitty patients with external warming devices like the blankets that we use and the circulating water blankets and the air infused blankets that we use. And I expect that most of you, if not all of you, are using that as well. But without nerve blocks and without keeping them really light, we used to run into a few patients that would get hypothermic on into 2.5 hours, especially the smaller patients. And it's not uncommon for us to do a procedure that requires full mouth extractions or near full mouth extractions or otherwise that take that long. And now we have, I can't remember the last time we had a patient that was hypothermic. So very effective in controlling that. And the other thing that happens is they recover very quickly. So we can't really turn the gas off until the patient has been cleaned up after the procedure. So the technician will clean and dry the patient while it's still under anesthesia, and then turn the gas off and the oxygen on after taking all the gas out of the system. And with that, the patient wakes up very quickly, within minutes, and is usually standing as the technician's brushing the patient to get it to look good to go home with the pet parent. So very effective from that standpoint. And guess what else that does? That minimizes your recovery time that you have to spend between patients. So you don't have to have someone watching the patient if they're standing on the table before you put them in the cage. And we can't say that for every patient, but I can definitely say that for the vast majority of patients, is when they go in that cage, they're already standing, and it's less than 5 minutes from the time that we turn that gas off. So very effective in doing that. And they go home and they are happy, and they're wagging their tail, and they walk out of there like they walked in. There's no hangover. And so we've made that into a habit to let owners know that we are doing anesthesia this way, and that is an amazing way to allay their fears with anesthesia. When we tell them we utilize nerve blocks to keep the patient almost awake, and that they wake up very quickly. We also obviously go over the catastrophic events like emboli that could happen, but in our practice, a patient is never going to be compromised from an anesthesia standpoint because it's too deep. We just don't let that happen with monitors, and not only mechanical monitors, but our human monitors. And we also use the Breathe Right by Jorvet, and so we can audibly hear that. And that's why I wear my hearing aids into surgery, because it's a high-pitched tweet. And if I don't have those hearing aids in, I can't hear that tweet. So I've got these guys in right now. I just came out of a procedure. So they are, that air bright lets the operator concentrate on doing the procedure, as long as you have that audible confirmation that continues, that tells us that patient's breathing rapidly, which is what we want. So next time, we'll talk about how we clear the airway, and some other things related to how we do things in our practice that you can translate very easily into your practice. I hope you enjoyed that episode. If you'd like more information about the Veterinary Dental Practitioners Program, please submit to request an invitation at ivdi.org/INV.